So now we're going to go over admitting patients in for surgery. We have a golden retriever here that's going to get spayed. So we have our admission form right here, which goes over the name of the patient, as well as the name of the owners, their address and phone number. It goes over the species, the breed, as well as the gender and signalment of our patient. We have our age and our weight on here as well. So this is our admission form. Our permanent records are actually in our computer. This dog is actually only 5 months old, so we have all of our records because we've been seeing her since she was a puppy. So I can go in here and pull up all of her history. So I can go right here and see all of our notes previously, as well as I can scroll down anywhere before us. Is when she was a puppy, and we have all of her vaccine records scanned in as well from before she came to us. So this is our admission form, and then we have our consent form for our spay. So we have detail right here that she's going to be hospitalized for about half the day. She'll get pain and antibiotics injections before surgery. She'll go under with fluids, or go under with anesthesia, run on fluids the whole time. That is the spay itself. These are our different injections. She'll go home with pain medication, as well as a nice little lampshade to go home to keep her away from her incision. She'll get a microchip placed while she's under anesthesia. And then we do have a laser during the spay, which is our CO2 laser. This is a cutting and cauterizing laser. And then afterwards we have a post-op therapeutic laser that promotes healing. So this is our estimate. And then we have back here where our client signs it. Says the last time our pet ate, gives a good phone number, as well as how we're going to contact them via texting, calling, in case we need to get a hold of them during the surgery or afterwards. So that is our consent form. Then this is our cage card that's going to go on her cage. We're obviously going to put her name, her surgery, what we're doing, her weight, as well as the doctor. So this is how we know which patient is getting what today. As far as lab forms go, say we needed to hospitalize Sky after the surgery. We do this a lot with cystotomies. This is our treatment sheet. This is where we put the patient's name, doctor's name, what we're here for, our weight, if we're going to do CPR. And then the doctor pretty much puts all of his orders on here. That way any technician that is running the hospital that day can just look at our treatments, see what needs to be done, and those get done. Another lab form we have is our dental sheet. This is for a canine. If we were doing a dental, we would put different notes on here as to teeth that were missing or extracted, and then we would put our stage of periodontal disease. So those are our lab forms. This is our anesthesia form. We'll put Sky's name as well as her species, procedure, weight in pounds and kilograms, obviously today's date. We'll also put her ET tube size, our anesthesia type, our fluid type, our fluid rate, and when the surgery is done, we'll write our volume infused over here. We also record our start time, and then our doctor start time, as well as anesthesia end time. So every 5 minutes, I'm going to be monitoring all of these things while Sky is getting her spay. Her heart rate, blood pressure, SpO2, capillary refill time, anesthesia, O2 liter, her breath rate, as well as her temperature. And any notes that Dr. Palma has during the surgery, I will write down here. So this is our anesthesia form. And then our very last form is for discharge. So when Sky's owners come to pick up, we will put them in an exam room, preferably before Sky gets in there. That way they pay a little bit more attention. We'll let them know to feed half the normal amount of food tonight, just because their tummy's still digesting a little bit of anesthesia. Start like normal the next day. If we had a dental, we would say to feed soft food or soften hard food with some warm water just because their gums might be a little bit sore. But for our spay, we're going to tell the owners to keep an eye on the incision site, make sure it doesn't look red, inflamed, or have any discharge, as well as that the sutures are still there. We're going to go home with a nice little cone lampshade to make sure that Sky stays away from the incision site. This can be taken off anytime Sky is eating, drinking, going for a walk, or that the owners are monitoring Sky. Anytime Sky is alone and is not being monitored, the cone needs to be on. That is especially at night or when we're in our crate. The hardest part for our puppies is keeping them quiet. So normally we don't have any external sutures to come out, but we do have internal sutures that can tear if she's being too rambunctious during the 2 weeks after the spay. We're going to go over the different ways to hold a patient for our different blood draws. So first is our jugular stick. I'm going to position my patient towards the person drawing the blood. I'm going to have our patient sit down. I'm going to have his body against mine, give him less room to move around. I'm going to move his collar back so the tags are out of the way, as well as up. I'm also going to secure his body with my elbows, again, to make him feel more secure and have less area to move around. I'm going to put his head up, pull the collar out of the way, and get my fingers out of the way. This way, whoever is drawing the blood has ample room right here to pull a jug on this side or pull from this side. But either way, I'm securing with both hands so I have control of the dog's neck as well as his body, which keeps me safe, the patient safe, as well as the person drawing the blood. So that was our jugular stick. If we were going to do cephalic, I would stay pretty much in the same area. The only thing that is different is I'm going to secure the head in a headlock. I'm going to put our leg out and roll over with my thumb to expose our cephalic vein, which is in our forearm. So now again, everything is secure. I can quickly move our head if I need to, and our arm is secure. So for our medial saphenous pull on the dog, which is actually lateral on a dog, medial on a cat, I'm going to have him stand up. I'm going to secure his head again with my elbow and have his body secure with my arm. And then I'm going to hold off down here with my thumb to apply pressure, which pulls up our saphenous vein down there for the person drawing the blood. So now we're going to get this patient out of the cage. I'm going to open the door, make sure he doesn't jump out because dachshunds are notorious for that. I'm going to put our leash on so I have control of his head. And I'm going to come over here, make sure I have good control of his body so he's not trying to jump away, and I still have control of his head. Now we move a cat patient out of a cage. I'm going to open it slowly to make sure that he doesn't try to jump out. I'm going to grab him by the scruff to immobilize his head, pick up his body. In this way, I have control of his entire body and especially his head. Now we can take him wherever we need to. So now Dr. Palma is holding for me and I'm going to place a muzzle on our patient. So this is adequate size for his muzzle. I find the quicker the better, give them less time to figure out what's going on. So Dr. Palma is going to secure the head. I'm going to place our small part over the nose, larger part under the mouth. And we're going to clip behind the ears, make sure we don't pitch any fur, and then we're going to secure this really tight so our dog can't bite us. And that is how we place a muzzle. This is going to go around his head. I'm going to tie this. I'm going to get it really tight. This prevents the dog from pushing it back off their head, but I can still fit 2 fingers underneath. That way he can still breathe. We're going to tie this really tight, and this way the cone goes past his nose, therefore he can't lick any incision that could be on his body. And that is how we place an Elizabethan collar on a dog. I'm going to do an exam and a TPR on this little schnauzer. She's about 3 years old, female spayed. So I'm going to start by checking her gum color. It's pink, and her capillary refill time is good. And then just get her pulse. So her pulse is about 150. She's a little bit nervous. That's an acceptable range though while she's in the clinic. I got her respiration as well, which is about 45. So now I'm going to get her temperature. So we get our TPR, which is temperature, pulse, respiration. I go a little bit out of order. I get my pulse first, respiration, save my TPR for last. That way it doesn't elevate my other numbers. And our rectal thermometers are the most accurate. There are ones for ears, but they are not very accurate, so we go ahead and stick with these. Our temperature 100.2, which is normal. I'm going to go ahead and listen to her lungs now. Very good, Molly. Don't see any eye or nasal discharge. Her pulses are strong. She is young, doesn't have any type of systemic disease. She's not on any chronic medication. So I would assign her an ASA grade of 1. We're going to do an exam and a TPR on a cat. So I'm going to start the same way, making sure that his gums are nice and pink. And they are, and they're not dry. So I'm going to go ahead and listen to him and get his pulse. So his is pretty fast at about 180, which is normal in the clinic for our cats. It's a little bit higher than the dogs. And I'm going to go ahead and count his respiration as well. So for our cats, we just want to make sure that they're not open mouth panting like a dog would. Go ahead and get our temperature. So anytime I'm getting a TPR for a dog or a cat, the way I count is for 6 seconds and then just add a 0. Hi, kid. Just go ahead and get temperature. You're doing very good, kitten. Very good. So this guy is here in the clinic just for his annuals today. He's only about 2 years old. He is, though, an outdoor cat. Normal temp at 99.5. So we're just going to be sure that we don't have any ocular or nasal discharge, which we don't. For an outdoor cat, his ears are actually pretty clean. I'm just going to look them over real quick, make sure there's not any scratches or bites, because this is how we get feline leukemia for these guys. And he does not have any systemic diseases. I know he's healthy and he has a great presentation, great body score, and I would give him an ASA grade of 1. Do a cephalic blood draw on this dog. He is anesthetized, so that's why he is on his side, which is going to make this really fun for me. I'm putting some alcohol on it to sterilize the area as well as visualize the vein a little bit better for me. Jack's occluding the cephalic vein for me. This is a 3 ml syringe with a 22 gauge needle. Go ahead and aspirate. And then I feel my vein right here. Go in. Back. I'm going to hold off. And that is our cephalic blood draw. So now we're going to do our jugular blood draw on a dog. And you're going to be good. So Mark's holding for me. He's going to hold the head up so I can work in here. So I'm going to get some alcohol to sterilize the area as well as make the vein pop up a little bit better. Holding off with my thumb down here. I'm going to take my cap off, aspirate the needle. This is a 3 ml syringe with the 222 gauge needle. I can feel the vein bouncing right here. Be a very good puppy. I'm going to go in with my needle. Pull back.
I have the Hendersons in room 30 picking up Bunny. Thank you.
Now hold off our saphenous blood draw on our dog. Lateral instead of medial on a dog. So I'm just putting alcohol on it to give me better visualization. Dr. Palma is occluding the vein for me. So you can feel it right here. Take my cap off, aspirate. And that is our saphenous blood draw on a dog. We're going to get our jugular blood draw on our cat. So I'm going to put some alcohol on here to sterilize the area. And I'm holding off right above the shoulder. It's okay, kitten. Good kitten. And that is all the blood we need for our test. So now we're going to do our medial saphenous blood draw on the cat. So Mark is occluding my vein up at the top of the leg for me. So I can feel my vessel right here. In, pull back. All right, hold up. All right, and that is all the blood we need. That is our saphenous blood draw on the cat. Now we're going to do our cephalic blood draw on a cat. I've already shaved the area. You can see our vein right there. Go in, pull back. Patients undergo anesthesia, there is a minimum database of blood values that we check to make sure that they can process the anesthesia okay. There are 5 of these values. The first one is our PCV, which is also called hematocrit. This checks the function of the red blood cells, makes sure we don't have any autoimmune or blood clotting disease. Normal values for a dog are anywhere between 37 and 54. Normal values for a cat are between 27 and 48. Our next value is our total proteins. This checks our oncolotic pressure, makes sure we don't have any dehydration or GI malabsorption. Normal values for a dog are anywhere between 5.5 and 7.5. Normal values for a cat are between 6.5 and 8.2. Our next value is our blood glucose. This can be artificially elevated due to stress or food, so it's very important to get a fresh sample. Normal values for a dog are between 80 and 130, and normal values for a cat are anywhere between 90 and 170. Our next value is our BUN. This lets us know how our kidneys are doing. This is very important for processing the anesthesia and making sure that the enzymes are eliminating waste from the blood. So our values for a dog and a cat are between 5 and 35. Our last value is our ALT, lets us know how our liver is doing. Again, the liver and kidneys are very important in processing and eliminating the anesthesia, so both of these values we want to make sure are within normal range. Normal range for ALT for a dog is between 8 and 109, and normal values for a cat are between 25, and 97. So we were going to do anesthesia on our sick or geriatric patients. What we would first do is a broader panel of blood work, something that specifically gets a thyroid as well as a urine analysis. Obviously a complete blood cell count with electrolytes. And then if we have any kind of heart problem, we would definitely be checking the ECG the whole time. And we'd most likely get radiographs before surgery to check the heart size as well as function. We might even do an echo of the heart first just to make sure we're perfusing well, as well as get blood pressure before our surgery just to make sure that everything's working the right way. So as far as pain management goes, we just did a mass removal on a 14-year-old dog. Pre-anesthetically, what we did is an injection of methadone. This is a lot safer for our patients, so we like to use these on our more geriatric patients. And then post-op, we're sending home Galliprant as well as Tramadol. So Galliprant we can use together with Tramadol for pain. It's also good for osteoarthritis, which is most likely going on because this is a 14-year-old patient. We're not doing an injection of Rimadyl post-op, which is what we normally do, simply because this dog is on prednisone, so we can't use things like Rimadyl for that. If this was a different surgery, say it was an orthopedic surgery, like a TPLO, we would actually do an epidural of morphine, and then afterwards, if we're anticipating pain post-op, we can do a CRI trip. Usually we use fentanyl or lidocaine for that. Other things for pain, if it's a difficult incision or a long incision, we can do a splash block or a line block of lidocaine and marcaine. We also use this a lot for our declaws. We'll do a ring block on each of the paws because this is a painful procedure. So now I'm going to put a controlled substance in our log. All we do is invoice it in the computer, and then it automatically assigns the name of the patient as well as the drug. So our patient's name is Eamon, and we use hydromorphone. This prints out on our log right here. So I go over here and find Eamon for our hydromorphone. Take this off. Stick this on here. There is a certain order that this goes in. For the way that ours works, it is paper, so we do 1, 2, 3, 4, and 5. So I have mine over here. It has my patient's name, as well as the doctor that used the medication and how much we used. So the doctor is going to sign right here of the dispenser, and then I'm going to sign right here that we witnessed this. Then that is how we do a controlled substance log. So now we're going to talk about our anesthesia machine. This is our machine right here. It first starts with oxygen. Our oxygen is actually made in the building, so we don't have to keep tanks on our machine. It comes through this green hose right here. It is picked up in our flow meter right here. And then it'll either go to one of our vaporizers for our anesthesia. So we have our ISO over here, but if we want to do SIVO, then we'll have our ports over here. The oxygen is what actually picks up the liquid anesthesia and vaporizes it to make it a vapor so the animal can breathe it in. So then that comes up here to our reservoir bag. This correlates to the size of the lungs of our patient. As this is moving, as well as our valve up here is fluttering, lets us know that the patient is breathing. So this comes up through here. This is our pop-off valve right here, which always needs to be open. Again, this correlates to the lungs, so if we're closing it off, that means pressure is building in the lungs. If we needed to bag the patient or breathe for them, then we would push this button and make sure that our dial over here doesn't go above 20 as we're breathing with our reservoir bag. This up here is the same thing. You can just twist it. It's just a lot easier to push this button. So the oxygen in the anesthesia runs through this tube, which is our rebreather. So it goes through the white tube. This is hooked into our endotracheal tube of our patient. The patient inhales the anesthesia and then exhales, which goes through our blue tube. and that is our CO2 is picked up in our soda lime canister, and then the excess gas is taken up in our blue tube here, which is scavenged by our active scavenger right here. And if we didn't have an active scavenger, we would go down here and plug it in here for our passive one. We use our passive scavenger if we don't have an exhaust tube. Say we needed to move this machine to radiology or ultrasound, where we don't have one of these, and we would use our passive one. So this is our rebreather system. One advantage of this is that since the tubes are together, it keeps the anesthesia warmer, which usually keeps our temperature higher during our anesthesia experience, which is good because we do have to worry about hypothermia. So this is our rebreather. This is our non-rebreather, which is what we use for our patients that are under 20 pounds, simply because this tube has a lot of dead space, which is really hard to keep all the anesthesia and oxygen moving for our smaller patients. So this is the same thing, it's just miniaturized. So these can only hook on one way, which is not that way. So this would pick up our SIBO. There we go. This would go to our patient, and then this would go to our scavenging system, either active or passive. This is our reservoir bag that's already on here, again, for the size of a small patient. And then we have our open and close valve right here if we need to bag the patient. Again, it is always open unless we are breathing for the patient, then we close it off and bag our patient that way. So this is our non-rebreather because the tubes are disconnected. This is also called a vein system. So if we needed to anesthetize a patient with our chamber, we would use this. So our patient goes in here, we lock it up, and then we hook up this instead of an endotracheal tube to here. We usually use this a lot for our fractious cats before we even place a catheter or an endotracheal tube. This makes them be a lot more cooperative. And if we needed to use a mask, we would just stick this on the end right here, and then the dog or cat's muzzle, which is their nose and mouth, would fit in right here, so they would breathe the anesthesia and oxygen. We use this a lot for our patients that are difficult to place an endotracheal tube. If they're being difficult and we don't have enough pre-anesthetic going on, then this can just help calm them down, give them a little gas while we place our IV catheter. So this is our mask, our chamber, and then our non-rebreather and rebreather for our anesthesia machine. The lead test on our anesthesia machine. So I'm going to close our pop-off valve. And then I'm going to fill up, or I'm actually going to close off this tube. Our air in our reservoir bag. I can see that it is not deflating, which means that it's holding pressure, and when I let my hand go, then it should come out. And now it is deflating. And that is how we do our leak test on our anesthesia machine. This is Dr. Holland. He's been helping me with all of my tasks up until this point. So this is my beautiful preceptor. Now we're going to knock out this little girl for her stay. So I have everything all set up already. We have our tape for our catheter. I like 2 big pieces, 2 little pieces. We have 3 scrubs, 3 alcohol, some dry gauze just in case things get a little bit bloody. I always prepare with 2 catheters, 2 different sizes. This is a really little girl, so I have a 25 gauge as well as a 22. and then a male adductor plug for our port. She's not going to be on fluids afterwards, so we don't need a T-port. So I'm just going to unwrap some of this, get it a little bit ready. We already have our endotracheal tubes out and ready to go, as well as our tie gauze. So I'm going to go ahead and start shaving for our IV catheter. When shaving for the IV catheter, you can go all the way around or just one strip. I usually go based off of what the doctor on the surgery prefers. And Dr. Unger does not have a preference whether we go all the way around or not, so I'm going to leave that alone. Sometimes shaving all the way around does more harm than good, and it ends up aggravating the patient. So I have my site right here. Jack's occluding the vein for me. I'm going to go ahead and do 3 alternating chlorhexidine scrub and alcohol to sterilize the area. And it also helps give me a better visualization of the vein. I dry the area around it as well, just so my tape will stick better. So because she is so small, I'm going to go with our smaller catheter. We always flush our catheters first to make sure they're working before they even get in the patient. So that's working. Put this back on here. So I have good flash going in, so I'm going to advance into the vein, pull out, still get flash. Jack is going to occlude the vein for me. Put my adapter plug on, and now I'm very sure to secure the port so the catheter doesn't go anywhere. I'm going to start with my skinny tape, sticky side up, go underneath the catheter, create a bit of an anchor. Then I'm going to go with our bigger piece, wrap around. So before I keep going with my tape, I'm going to flush the catheter to make sure we're patent before we get too excessive with our taping. I'm going to push this in here. And then Jack's going to feel the vein for me. So then I'm going to proceed with my smaller piece of tape, create an X for a further anchor, just to make sure my catheter is seated really well. And then one last final piece just to make sure this is secure to the patient. Throw all this away, get our sharps out. We're going to place a saphenous catheter on the dog. I've already clipped the area. So now I'm going to scrub it. Have our Chlorhex scrub and our alcohol. I already have all my tape set up, as well as my catheter flushed and ready to go. Just going to dry the sides so my tape sticks a little better. So this, even though this is a big dog, this vein isn't very big, so I'm going to use a 24 gauge catheter. This dog does not need to be on IV fluids afterwards, so I have our male adapter plug right here. Dr. Palma is occluding the vein for me. Even though it's popping up really good right here, there is a valve, so I'm going to go above that so I don't hit it. So that will stop the feed of my catheter. This is a rather wiggly vein. Dry gauze for this purpose. Now we have first our skinny piece of tape, sticky side up. This is to create a nice anchor. Usually the taping is the most fun part of this catheter. This is my bigger piece of tape, which is going to help seat my catheter. This is on tight. I'm just going to do a cross piece, again sticky side up. And then I'm going to add one more piece of tape to make sure our tape is sticking to the patient. So now I have some saline flush ready. Dr. Palma has his hand on the vein. He's going to feel for me to make sure our catheter is in. It is. So now our dog is all ready to go with his Vtht IV catheter. So now we're going to do a sub-Q injection on a dog. This is an allergy injection. I already have it drawn up in my 3 ml syringe with a 22 gauge needle. So I'm going to pull the skin up right here, feel my tent. I'm going to push the needle in, draw back, make sure I don't get any blood, which I don't. Push all the way in. So we're going to actually reverse this dog. She's sedated right now, so I'm going to give a reversal of antecedent, IM. So I have my hand on the stifle covering our femur right here, so I'm not going to hit the sciatic nerve. Go right back here, feel this nice fleshy portion. Go in, pull back, make sure I don't get any blood. Do an IV injection on this dog. So Courtney is occluding the vein for me, as well as keeping his head away from me. So I'm going to put some alcohol on here to sterilize the area, as well as see that my vein's popping up. You can see his bifurcation right here, so I'm going to go above that. This is just sterile saline. I have a 25 gauge needle on here.
Really? Yeah,
I'm gonna go.
So yeah, that maybe. So I think she's feeling better because she doesn't want to
in,
throw up. So
pull back. I see that I have blood. Courtney's gonna hold off or hold up, and then I'm gonna get my injection. So we're gonna knock this guy out for his neuter. Our induction drug today is alfaxin. So we normally use propofol, but this one is pretty new, and we're going to titrate this to effect. So I'm going to give a bolus 4 times. So I'm going to crush about 1/4, Wait about 30 seconds. Push another fourth, and that's what I'll keep doing until our puppy starts to go to sleep. Make sure he loses his jaw tone, and that's how we know we can place our endotracheal tube. I already have my tube and tire gauze out. The way we pick our size is the width of the tube is supposed to fit the width between the nostrils of our patient. Go ahead and just add a little flush more of our alfaxin through. Hold the tongue back, pull down that epiglottis, slide right into the trachea. Jack's going to hold our tube in place. Our gauze behind the canines, and we'll go over the nose. If this was a cat or a brachiocephalic dog, we would tie this behind the head. So we're going to go ahead and turn our patient while we're not hooked up to the anesthesia so it doesn't twist our tube. And now we can hook them up. I'm going to inflate our cuff. So this piece of the cuff correlates to the cuff inside the trachea. So that feels pretty firm to me, which is what we like. This prevents aspiration. And the way we measure this on here is anywhere between 20 and 30. Is how we know we have enough pressure. So I'm going to put on our eye loop. Finish giving our medication. Now we're going to disconnect the patient, turn him, so before I scrub, I'm going to express the bladder. This guy has really good owners, and they made sure he was empty before he came in. So now I'm going to clip the area.
We have Ms. Wright trying to get information about her best source delivery. Line 1. Thank you.
So this guy's getting neutered today, so that's what I'm going to clip for. If this was going to be a spay, then I would clip all the way from xiphoid back, as well as to my margin right here. Scrub the area. Again, I'm going to do 3 alternating of scrub and alcohol. I'm going to start at the incision site and work outward. This guy though is super dirty. So I'm going to make my initial scrub to just clean him up.
Everybody's like, that's fine. I don't care. I got too much crap to do. You should have that dying heart failure fixed. Oh, no, you need more of it, so it's okay. You're like, sure.
Now I'll go from our incision, radiate outward. I'll do this 3 times out here, and 1 more time once we move to surgery. Now that I finished our scrub out here, we're gonna sling our puppy to the OR room. I'm gonna detach. So the first thing we do when we come into surgery is hook our patient back up to our anesthesia as well as oxygen. And then we're going to tie us into our table. Now I'm going to place our blood pressure cuff. I do this on this side since our IV catheter is over here, and that's where our fluids will be running. So I'm going to do this blood pressure cuff is about 45% of the width of our foot. Go ahead and start this. I'm going to place our ECG leads as well. We can monitor the electrical activity of the heart during surgery. So we're going to put our white lead on the right side, black lead on the left, and our red here. Go ahead and put some alcohol on these so they'll read better. And here we have our pulse ox that I'm going to put on the tongue where it reads the best. If this was something like a dental where we need it to be in the mouth, though, we can place this on the ear. Anywhere where we have good skin contact. So if we needed to, we could also place it on the prefuse of a male dog or the vulva of a female dog. Now I'm going to place our esophageal temperature probe. Goes right next to the trachea. That way we can keep an eye on our puppy's temperature the whole time during surgery. I'm going to place our capnograph right here in between our ET tube and the anesthesia. And this will monitor our respiration rate the whole time. So now now I'm going to do a final scrub. Again, starting at our incision site, working my way out. And I'm sure to never retrace my steps with the same piece. And anytime the piece hits hair, it is contaminated and I get a new piece. And now our puppy is ready to be draped in by our doctor. During the surgery, I'm going to be monitoring our vitals every 5 minutes. This is my machine where I'm going to get all my vitals from, although the best practice is to get it directly. That's how you know that all your numbers are going to be correct. So the whole time, every 5 minutes, I'm going to monitor the time, our pet's heart rate, blood pressure, SpO2, our capillary refill time, make sure our anesthesia is at the right level, our oxygen, how much we're breathing, and our temperature. We do this every 5 minutes from the start to finish based off of our machine right here and getting all the information myself. So now Dr. Romo and I are ready to do this canine neuter. So unfortunately at our clinic we do not have an esophageal stethoscope, but how it works is a tube that goes down the esophagus. This is where we want to make sure our endotracheal tube is placed correctly, so that way when we're placing the esophageal stethoscope there's only one place for it to go. So the tube goes in the esophagus, which functions as this piece of the stethoscope, and then this piece actually attaches to it as well so you can listen. These are important in our thoracic surgeries to give us a really good listen to the heart. It is also important or useful if we're draped in really extensively, so we can't get under the drapes very well to listen to the patient directly. So we can just use the esophageal stethoscope in these cases. If we needed to do CPR on a dog, first our dog would be on the table, laterally recumbent. We would have an endotracheal tube placed. We would hook up our line to the tube. A doctor would be doing compressions on the dog, and then we would close our pop-off valve completely, and then this would be flowing with pure oxygen. We'd do a couple breaths with our reservoir bag, open up our pop-off valve again, let our dog completely exhale, and this is what we would continue doing until the dog is breathing normally on its own. So now I'm going to do a surgical scrub. So I'm first going to take off my watch and my ring, put on my mask, gonna be able to explain. So I'm putting everything on now before my hands are scrubbed. So I don't have to once they're already scrubbed, because then they're clean. I can't touch anything. So now I'm gonna scrub. So what's important here is contact time. First, I'm going to start taking this on my hand. I'll put the contact. And then I'm going to use a finger pick to get under my nail. I'm going to do this on both hands. I drop that in the sink. I'm going to do all 4 sides position of each finger. This initial scrub is supposed to take 5 minutes. And then any subsequent scrub, if we're doing surgery all day, and that's all we're doing, it only needs to be about 2 minutes. I'm actually going to come all the way down here too. And do the same thing with my second hand. And again, it's more of the contact time of the scrub with my skin that is going to make everything clean. Now I'm going to go ahead and drop this in the sink. I'm going to keep my hands up so everything will drip down my arms away from my hands that are now clean. We're going to come over here, grab my towel. So I'm going to clean one hand, one side, and then the other hand, the other side. And we'll go ahead and drop this. And I can pick up my gown. I kind of just want this to fall open. And I'm touching the insides because that's what I'm going to put on. I'm going to be sure to not touch anything, as well as keep my hands inside the cuffs now that they're clean. So I'm going to close glove now. I'm going to start with my right hand since it's my dominant hand. Sorry. So I'm going to pick this up with my cuff. Again, not touching anything with my fingers. I'm going to put cuff inside. I'm going to do the same thing over here. Again, keeping this inside the sleeve. It's not always pretty. Pull this down. And then I will ask our non-sterile assistant to tie me in. So I will hand her this part. Turn around, and now I can tie myself in. So now I will keep my hands up, and we are ready for surgery. The surgery tray ready for Dr. Romo.
So our non-sterile assistant has already opened our drape and dropped it on here, as well as our scalpel blades. So I'm gonna open our hot towel, which is sterile. And again, we have our sterilizer strip in here that lets us know that it's sterile. Gonna move our gauze out of the way. If this was a spay pack, then I would take the spay hook out to free all my instruments. So now I'm going to use I'll load our pen blade with needle holders onto our scalpel holder. So this slides on, clicks in. Now I will drape the patient. How I do it is I put the drape on the patient. This is a mask removal. Our mask is right here. These scissors. I know our mask is right here, so I'll just take this up and create our AVMA right here. Okay. Now we're all ready to go for our mask removal. So I'm in surgery with Dr. Romo right now. I'm helping her assist. She does have some blood that I'm going to blot for her. So Jack is going to sterilely open some gauze for me. I can touch this with my sterile gloves.
Thank you. Danielle, can you moisten this tissue for me, please?
Again, Jack's going to open this one. Out. Thank you.
Scalpel blade, please.
Please.
Thank you. Needle holders. Thank you.
So when passing instruments to our doctors, I'm going to pick it up and then hand it to her so it's ready for her to use. Exactly where she's going to hold it in her hand. Again, cutting down on time so she could go as quickly as possible. So a lot of the responsibilities of a sterile technician is running the instrument table for the surgeon. We're passing them instruments, anticipating what they need next. That way we have our patient under anesthesia at the lowest amount of time. If there is a break in sterility, such as dropping an instrument or we need new gloves, the instrument that is dropped is then dead and a technician will have to open a new one sterilely and aseptically to pass to us or the surgeon. If we need new gloves, they will pull ours off and our hands will be inside the cuff, and then they'll bring us new gloves that we can still close gloves so it'll still be sterile. As a sterile technician, we do have to maintain sterility, and there are certain ways that we do that. A lot of times we're keeping our hands up and we're not touching anything that is not sterile. So we can touch anything that's in the pack, and the patient and the surgeon, but we have to make sure we're not touching anything else because then we're not sterile and we will interfere with the procedure. We also have to have a very surgeon-like conscience. So if there is a break in sterility, even if no one sees it, we have to be conscious of this and write it as soon as we can, because this will negatively affect the patient. So now Dr. Romo and I are ready to do our canine neuter. Now we're both gloved up, ready to go to do our feline spay. Dr. Palma and I are about to do a spay on this canine. So now we're both gloved up, ready to go for our feline neuter. So we're done with our first surgery of the day, so I'm going to go ahead and clean the surgery suite a little bit. I'm going to first start by taking our sharps and putting them in the sharps container. We didn't have any tissues that need to be put into the biohazardous waste. I am going to take out the trash. We'll clean this. We're going to change our towel in between surgeries. We didn't have any blood on the floor for this surgery, so I won't need to mop until the end of the day, which we'll use our wet mop for that. I'm going to use chlorhexidine scrub for our table as well as our lights. And then again, this is only our first surgery of the day, so at the end of the day, I'll do more of a deep clean inside the entire surgery suite with wet mopping the floor. So this is ready for our next surgery. We'll take and clean our instruments, and that's how we clean the surgery suite. We're going to clean our instruments. So we've been pre-soaking our surgical instruments in distilled water and an enzyme solution to kind of get the big debris off. So now we're going to just rinse them with water. And so we're going to make sure that these are open, and we're going to use a soft bristle brush to get all of the blood off. And I'm going to pay special attention to the box flaps. We want to make sure nothing is caught in there. We use a soft bristle brush because anything hard like wire can create micro crevices for microorganisms to stay in there. So I'm going to put these over here for each one to dry, and then we're also going to put some lube to keep the box locks and ratchets working well. So I'm going to do that for all of these instruments, and then we will come and wrap them. Now we're going to wrap our spay pack. So I have my green towel pack down in a diamond shape, and I put our blue hot towel right here. These instruments have already been rinsed and cleaned. So I put these in order from straight scissors, curved hemostats, and straight hemostats. I have our Alice tissue forceps at the end, as well as our needle drivers. I'm going to put our big occluding hemostat on the bottom, as well as our single holder. Then I have our towel clamps to the side, and then I'm going to put our thumb forceps on the side. This will just help us know where everything is when we start to open the pack. And I'm going to put our spay hook through the handles right here. Lay these over. Put sterile gauze on here. And this is our sterilizer strip. So when we open the pack, when it's done in the autoclave, we know when this has stripes on it that it is sterile. So I'm going to start with my blue hot towel. Just going to do the bottom, the top, and the sides. Yeah. I was like, I'm sorry. We do want this to be tight, but not too tight to where the steam can't get through. I'll start with the bottom. Up. And then we'll come down in an accordion-like fashion. That way when we're opening these, we can just pull on the tabs. So I'll do the bottom, side, again in another accordion. I'll do the other side, same way. Top over, and then this will tuck here.
She kind of got offended when she found out I
So we can just pull this tab. And it's tight. Okay.
really offended really easily.
Like, no, I don't know anyone else that does that.
Yeah.
And I'm going to put that this is a
black spray pack.
It's not here. You can give it to one of these.
I'm also going to put the date on here so we know when this was done and my initials. We're also going to put our sterilizer tape on here. So this is just another way to let us know that our pack is sterile. We don't use as big a piece of tape as this because it is more expensive. So now that we're done with our pack is ready, open the autoclave here. So when I start the autoclave, I'll actually take this out because we don't want our pack to be touching the top tray or the sides because this will inhibit the way it gets sterilized. So we close it. Make sure it's really tight. And then ours is already preset.
Are you filming anymore?
So we just turn it on. And this is already set for us. And then I'll just press start. Now we're gonna wrap our gown. I'm gonna put front side up. And pull our sleeves over on each side. And we'll fold it down the center, each side. And then I'll accordion fold it in. Cuff first. Now we'll accordion fold in. I'll do the same thing going this way. Accordion. And then I want to make sure these are on top because this is what the doctor is going to hold on to. I got the gown, our hot towel, and our sterilizer strip. Place it on here. So I'll just put it in the compact. So it's this sterilizer strip that will have a black line across it once it is sterile. And that's what we want to see when we will open pack later. So we'll start similar to the surgery pack, folding it accordion style. On the bottom, sides. Sure this is really tight so it'll fit in our autoclave, and then this tucks in there so we have our little tab to open it, and we'll just tape it up again. So I will write my initials, the date, so we know when it was done, and if this is a gown. We will also put our sterilizer tape on here, which is just another measure to make sure that we're getting full sterility. And that is how we wrap the gown. This is our autoclave. It is a gravity air displacement sterilizer. So how it works is that it heats distilled water, which pulls air out of the sterilizer. That creates a steam pressure build. So once it reaches optimum temperature, then it sterilizes the instruments in there. It runs for as long as it needs to sterilize those instruments, and then it forces the air back out, which condenses into water. That is how this autoclave works. Our autoclave works is it needs to reach optimum temperature, which is between 250 and 270 degrees Fahrenheit. It takes about 15 minutes for it to reach this temperature, and then needs to run anywhere between 3 and 15 minutes to sterilize the packs. The time it takes to sterilize depends on how many packs are in there and how big they are, and then that is how it sterilizes. So the temperature is between 250 and 270 degrees Fahrenheit, and the PSI is between 15 and 27. So to maintain our autoclave, we always have to make sure there's enough water in it. This light down here will tell us that, and we put it in through here. So maintenance-wise, weekly we actually use this. This is what scales the chamber as well as keeps all the trays clean. And then monthly, I make a solution with this, which we also put in here. We have to make sure there's not any equipment in the autoclave at the time. We actually take out all the water and then add this solution, clean it, and then replace the water. We also have to make sure our gasket is replaced at least yearly or as needed. This is actually maintains the PSI, which is what activates the steam to actually sterilize our instruments. So this is our autoclave and how you maintain it. Autoclave is done, so we're going to open our pack by unpacking the autoclave. So we can see that this tape is striped now, which means that it has been sterilized. Now we'll open this. So when we open this in surgery, what we want to see is that this is now black, so it means everything inside the pack has been sterilized. So now our gown pack has been autoclaved, and our tape has stripes on it now, which means it has been sterilized. So we'll go ahead and open it. So what we want to see is that this strip is now black, so everything underneath it, the hot towel and the gown are sterilized, and we're ready for use. So I'm going to remove some external sutures from a patient now. We do have this patient gassed down, so I'm just going to go ahead and remove these with our suture scissors. So I'm going to pull up the knot, put the hook end underneath, and pull my suture out. There's one. And the way that we know that these sutures are ready to come out is that the skin is opposing together really well. There's not any redness or inflammation. Some scabbing is okay. I think that's actually pretty normal as a part of the healing process. But the skin again is opposing back together well. There's no discharge, redness, or anything swelling up underneath like the dog could have been looking at it or anything like that, as well as the sutures are intact.